Hello, everyone. Welcome. Good morning, and welcome to the Neurological Symposium, where, as you know, our mission, the McCourt Foundation, is striving to cure neurologic disease while empowering others to build a healthier world. And we're governed by three pillars, and one is funding research, another is empowerment of our other partners and communities to help build a healthier world, and we do that through our events, our athletic events. And the last one is education. And today, today we have, as you all know, we're broadcasting this, streaming it, and there's 5 countries, 16 states, and 137 towns and cities people have signed up from. So it says a lot for the need for this information and a lot about these physicians here and the work they're doing. So I would like to just do a special thanks to our major sponsors, which is InvoCare RX, Novartis, and Leader Bank. So thank you all to all of our sponsors, though, because if it wasn't for your support, we couldn't put on programs like this, where again, it's free for anybody who wants to come here or who's tuning in. So thanks very much. And with that, I'll hand it over here to Eric and let him start the first session.
Great. Thank you, Brian. It is a real pleasure to be able to moderate 3 wonderful talks this morning, and then a time for question and answers from both our online audience and those that are in person here today. We thank the McCourt Foundation for being wonderful partners in our mission, and that relates to patient care and research, of course, but today we're focusing on education. And I have really enjoyed these past opportunities to hear from my colleagues about the wonderful work that they're doing, but also exciting advances in the field. And each year, I think the wonderful thing about practicing in the area of multiple sclerosis and neuroimmunology is that each year we make strides. Each year we have advances and new treatments. And this is a great opportunity to share that with all of you. So I have the pleasure of introducing our first speaker today, who is joining us remotely from Los Angeles. Dr. Nancy Sicotte is a professor in neurology and the Women's Guild Distinguished Chair in Neurology at Cedars-Sinai in Los Angeles. She is a wonderful colleague that I've known for now almost 20 years, and I'm excited to hear about her presentation on biomarkers and advances in how we diagnose multiple sclerosis. So please, Nancy, go ahead and take the mic.
Thank you, Dr. Klawitter, and greetings from my kitchen in Los Angeles, Culver City to be exact. I'm hoping one day I will physically be able to join you in the great city of Boston, where I actually was born and raised just up the road in Salem. This is such a great symposium every year, and I went back and looked at my slides from last year, and I would say that my presentation this year is sort of an update. We've had some great advances in now what has been a long road to develop new imaging biomarkers for MS diagnosis, and they're now being codified. So it's really an exciting time, and I've actually I'm sort of surprised, Eric, to hear it's been 20 years that I've known you, because you seem like such a youngster to me. But in looking at the what's been going on in the world of MS, this slide kind of highlights what's happened during my career in MS. So if we look back here to 1995, I was just finishing my training. So yes, I'm old. And there was really just one therapy for multiple sclerosis at that time, beta seron. And you can see what's happened. There's just been an explosion of therapies over this time period. And I really think that MS, as I in my role as chair, thinking about neurological diseases in general and overall, and you're going to hear more later on today about ALS and Alzheimer's disease. But I think that MS is sort of the poster child for the neurotherapeutic era. We have advanced the field during this last 25 years and really modified the disease. And we're getting very close to being able to, I would say, even prevent people from ever having a symptom related to MS, in part because of the work I'm going to show you. So I think that we have to take this perspective that while we still have things that we need to work on, and we'll hear more about progression in MS, and that's our next thing to tackle. It's, I think, helpful to look back and see how much progress we have actually made with the therapies that we have. And because of these therapies, we have thought about the importance of making a diagnosis very early, because we know from the work that has been done on therapies that the sooner you make a diagnosis and start treatment, the better people do in the long term. And we have good data to support this. And so part of what's been happening in the field of MS is trying to figure out ways to make a diagnosis early, an accurate diagnosis. And we've done some work on misdiagnosis, which can happen. But in order to get treatment started early, we need to be able to identify those patients who need treatment. And we have seen with the evolution of our diagnostic criteria that you see displayed here, that starting in the previous era of poser criteria, going all the way down to McDonald's now 2017, and we have a new diagnostic criteria, which I'll tell you about from 2024. So we'll have to update this graph, but you can see how the time to diagnosis has been decreasing. And if you look from Poser to McDonald, it's a 77% decrease in the time from a clinical event to an MS diagnosis. And I think this is really very important, because we see now much better outcomes in our patients if we're able to identify the disease early and get people on highly effective therapies. The other evolution, and again, a bigger picture kind of thought about this, is that as we think about neurologic diseases, we're really moving from um, an era where we had phenomenology or clinical presentation as the hallmark of how we would make a diagnosis. And we've moved now to more biologically based diagnoses. And this, I think, is a huge advance. And it is the sense that we've moved from what we used to call diagnose and adios. So we would make a diagnosis, spend a lot of time doing a careful exam, but we really didn't have a therapy. We're now in a therapeutic era, and we're really leveraging advances in these biomarkers in order to make a diagnosis accurately and early. So the new revisions, the 2024 revisions of the McDonald criteria have just been published in Lancet Neurology 2025, but they were first presented in 2024. And this is, again, another iteration of an advance in our ability to identify patients who have MS, and also to help us to identify patients before they have symptoms and make a diagnosis. And the paper immediately following this in the Lancet is our Magnum's consortium and names MRI criteria for MRI. And it turns out that MRI is a very important component of these new diagnostic criteria. And we are now officially incorporating some of these research related biomarkers that we've been working on for more than a decade. They are now officially in the diagnostic criteria, which is a huge advance. And those new MRI biomarkers have been talking about for, it seems like a long time, but MRI, as you know, is very important in our diagnostic criteria, and we used MRI to give us dissemination to satisfy the requirement for dissemination in space. So we have these canonical areas: the periventricular, cortical, juxtacortical, infratentorial, and spinal cord. And now, new this year, we are including the optic nerve, which many of us have felt has been very important. But in addition, we have two very specific imaging biomarkers that are now part of the criteria: the central vein sign, which is the ability to see a small venule in the middle of an MRI lesion, of a flare lesion, that is very specific for demyelination. And then I think very exciting, this new paramagnetic rim lesions, which you're going to hear more about in subsequent talks. These are very specific, as we'll see, for MS, and maybe telling us something about the disease and about prognosis going forward. And then, of course, dissemination in time, we use new T2 lesions or gadolinium enhancing lesions, and that has not changed. So I'm not going to go through this, belabor this. Many of us are still wrapping our brains around the new 2024 criteria. It's pretty complicated, but I want to highlight that a lot of these include MRI. So the central vein sign has now been incorporated for a diagnosis, the paramagnetic rim lesions as well. We're now using a different kind of oligoclonal band or CSF marker, kappa light chain, as a paraclinical test. And radiologically isolated syndrome now can be diagnosed as MS. And I think, again, this is showing us that we could potentially prevent patients from ever having a symptom related to demyelination by giving them a diagnosis and putting them on treatment. And so this is, I think, an advance, and I think I want to highlight the role that MRI is playing in this evolution. So as I said, the optic nerve is now considered one of the locations. It's the fifth anatomic locations, and we can now actually diagnose patients even if they have only one of these locations based on some of the other biomarkers. But this is just highlighting how imaging would play a role in differentiating MS, which is typically associated with a unilateral optic neuritis, from something like neuromyelitis optica that involves bilateral optic neuritis, as you see here, or involvement of the optic chiasm, as well as other kinds of MOGAD, which is MOG-related demyelinating syndrome that has involvement of the entire optic nerve. But this is showing how MRI could be used to distinguish these two. But for many patients, they present with optic neuritis. This allows us to make a diagnosis at the time of that presentation. So again, I'm not going to test you on this, but here are some of the flow sheets that have resulted from people who are presenting with typical symptoms. We can do our usual kind of workup and make sure that there aren't better explanations. That's always part of the diagnostic criteria. But what I want to highlight here is that having the central vein sign can contribute to the diagnosis, and as well as having paramagnetic rim lesions in addition to a CVS or CSF oligoclonal bands or kappa light change. So these MRI markers that we've been working on all these decades are now in the official diagnostic criteria. And the other thing that's very, I think, exciting is this is a diagnostic algorithm for radiologically isolated syndrome or non-specific presentations. So we've been working on a project called the CAB study, where we've enrolled patients who've come to the clinic with a suspicion for MS, and we are looking at how we can best diagnose those, because this is pretty typical for what shows up in our clinic. People may not have a classic MS presentation, and we are now able to diagnose these patients with the inclusion of these more specific biomarkers. So this is, again, people who have kind of funny symptoms, and some of you who live with MS may have gone through this very difficult time where they couldn't actually give you a diagnosis for a period of time. We're able to do that much quicker now and more confidently because of these new biomarkers. So just to highlight the role that the central vein sign and paramagnetic rim lesions are playing in a typical presentation, you can have dissemination in space with the topographies plus a CVS, and that will give you MS. But you can also have one topography, so one area of the central nervous system that's inflamed with dissemination in time, which could be demonstrated by spinal fluid, but now a CVS or pearl lesion will give you a diagnosis of MS. And in radiologically isolated syndrome, the CVS also plays a role in making a diagnosis without someone actually having a symptom. So the thing that makes this so exciting for us is the specificity that we see. And in particular, we see with the central vein sign and the pearl lesions, having one or more pearl lesions has a specificity when we do this analysis of several studies of over 99%. So again, giving us confidence that we're making the right diagnosis. And the other thing that I think wanted to highlight is for many years, for those of us who do research and imaging, have published multiple papers and have done interesting work, but it really hasn't hit the clinic. So we're now translating all of these findings into clinical practice. And this is the paper that follows the McDonald criteria update. And this is our recommendations for susceptibility weighted imaging that would allow us to see both the pearls and the CVS. And this will allow our colleagues to also implement this in clinical practice, which is our goal. So just showing you how in our scanners, the clinical scanners at Cedars-Sinai, we are now routinely obtaining these imaging metrics. Here's the central vein sign. You can see very characteristic, and these paramagnetic rim lesions. And this is an FDA approved sequence, and we are now in the process of disseminating this across the country. That we're going to hear more about pearls. These are fascinating lesions that we think may play a key role in progression going forward, and we're going to hear more about that. But the ability to be able to identify these early will help us with diagnosis and prognosis. We have been looking at these in our CAV study, and it's really interesting that we're finding lots of paramagnetic rim lesions, even in patients in their initial presentations for MS, which is not necessarily what folks were thinking. These are probably evolving over time, but they allow us to make this diagnosis early and get people treated. We think that they may be, as I said, informative for diagnosis, but perhaps associated with disease severity. And you'll hear more about cognitive areas, cognitive dysfunction, as well as progression going forward. So this would help us to identify people early and tailor our therapies. And you'll hear more about using 7 Tesla to investigate this in our next talk. So I just wanted to highlight a really interesting finding. These new treatments that we're developing for MS, the BTK inhibitors, showed that there was a slowing of disability progression in non-active MS. So these are patients without inflammation, but the benefit seemed to be driven by those patients that had these paramagnetic rim lesions, suggesting that we may be able to stratify patients into different treatments based on these MRI biomarkers. And then finally, just to highlight that we are working very hard to translate this to clinical practice. And one of those involves working very closely with our neuroradiology colleagues. So Marcel Maya is our chief of neuroradiology at Cedars, and he has now implemented this in their templates for the readouts of our MRI scans. And this is incredibly helpful. So they're reporting, radiologists are reporting to us whether or not patients have pearls, how many CVS lesions they have, and along with cortical lesions and brain atrophy. But this has really been transformative for our patients. We can now show them that they maybe don't have MS, which has been helpful, but also this will help our colleagues who are in private practice or out in, who are not necessarily in academic centers to have this information. So we're working hard to get it into the clinic throughout the country. So I just want to acknowledge all of my collaborators and colleagues, the NAMES Consortium, which has been really working on the central vein sign and now paramagnetic rim lesion implementation, and our funders and my colleagues at Cedars-Sinai. Here we are at our walk that we do for the National MS Society, and particularly want to highlight Pascal Satie, who has been a leader in this area for more than a decade. So thanks again for the opportunity, and looking forward to taking questions as we go to the panel. Thanks.
I have the pleasure of now introducing Dr. Jonathan Zurawski, who is an MRI expert at the Mass General Brigham, and he is an assistant professor of neurology at Harvard Medical School. And he's done really excellent work over time applying high field or imaging up to the 7 Tesla platform clinically, using it in the clinical setting for multiple sclerosis. And I look forward to his talk today on advances in progressive multiple sclerosis.
Great. Thank you, Eric, for the warm introduction, and thank you to the McCourt Foundation for the opportunity to speak here today. And as Eric said, it's really an exciting time in MS, and we have the luxury of having new tools to both monitor MS, diagnose MS, and make prognosis. And some of what I've talked about here really tags along nicely to what Dr. Sicotte's talk highlighted. So I hope walking away from this talk, you'll leave with a sense of optimism about a stage of MS that historically has been very difficult to treat. And so my talk is entitled New Advances in Progressive MS, and I'll be highlighting neuroimaging advances to that effect. So I put this sentence up here to start, and thanks firstly to all the patients in the room who came today. I wonder how many of you have heard this phrase, have read it implied online, or if you yourself have even thought of this. But many patients come to me at the Brigham having heard this before, and I really urge patients and colleagues to move away from this style of thinking. And I hope that in reviewing the imaging and therapeutic advances, you'll see that there's actually a lot to be optimistic about in MS. And so I never use this phrase in my clinic. Many of my patients are actually on the Zoom today, and I think could attest to me being sort of an optimistic neurologist. And I think, as Dr. Sicotte alluded to, we're really at the forefront of advances, and MS is an area of optimism. So historically, this is what a graph of the natural history of MS looks like. And on this graph, you see depicted in blue relapses that occur over time. And along the very bottom, the x-axis, you'll see gadolinium listed. And so MRIs show enhancement along with relapses. And then eventually, as you reach a later stage of the disease, you'll see that there's gradual disability, but not much happening in terms of the conventional MRI scans. And this is a really frustrating thing for any of you who may have had worsening while your MRIs are totally stable. You come in for your clinical visit, and the MRIs are done, but they really don't reflect the clinical reality. And so I would argue that advanced imaging can help us to better understand this stage of the disease where our current technology does not correlate well with disability. One of the tips that we have to think about how imaging can better understand progressive MS comes from basic histology. So if you look under a microscope at MS, you'll see that in the relapsing stages of MS, depicted in green on the first panel, you'll see that classic periventricular white matter lesions in MS. And that's what we know to be the medical convention, which we learn on day 1 of medical school in MS. As you move toward the progressive stages, you'll see the pattern differs for the next 2 pictures, in that depicted in orange, you have subappeal from the very surface of the brain, cortical demyelination, And while there are the classic periventricular lesions depicted in green, they're relatively sparser, and actually more of the pathology is driven by what's going on the surface. And so a transition happens at some point in MS, but I'll ask you then to look back to that first panel again, and you will actually see that the cortical demyelination happens from the very earliest stages, and we think it gradually accrues. We don't have great tools to monitor this, but one of the things that you can see from clinical studies of MS is that there actually may be more of a gradual worsening of MS from onset that has not been well appreciated. We now know of a concept called progression independent of relapsing activity, or PIRA. You'll hear about this in trials and other data that shows that MS patients can actually gradually worsen over time, even from the relapsing stages. And data from large retrospective pooled data sets and from clinical trials shows actually that the amount of disability that you see within a trial is more largely comprised of PIRA. And I showed one example here where 27% of a large 5,000 cohort group showed PIRA versus those who have relapse-associated worsening, only 17.8%. When we first saw this data, we were left scratching our heads. We know that progression evolves, but it doesn't happen at a finger snap transition point. And when you see these observations from clinical trials, it matches more with what we see based on basic histology, which is the disease is a gradual continuum. And as Dr. Sicotte alluded to, we're moving more toward a biologic understanding of progressive MS, the different processes underlying what's driving it, rather than just saying, oh, you have a cane, and so you must be progressive. So I would argue that we should reframe that first picture I showed you with a gradual line from the earliest stages of MS, where we're using higher resolution MRI and other tools like biomarkers, pleural lesions, to try to get a sense of what is driving that progression. Now, this may be more complicated than you were hoping for at 10 a.m. on a Sunday, but this is what we think is the sort of cutting edge of what is driving PIRA. There's different kinds of pathologies: axon loss, chronic active lesions, as was talked about in the prior talk, brain and spine atrophy, cortical lesions, and meningeal inflammation. And depicted upon the bottom is actually what we think is a biological transformation that happens between the early stages of MS and what we know as the later stages of MS, a shift in immunology and relapsing inflammatory pathology that's driven by relapses in the early stages actually shifts to something that's more gradual, that involves neurodegeneration and trapped inflammation inside the brain.
So this slide depicts imaging examples from our 7T MRI scan at the Brigham Women's Hospital, which shows us some of the pathologies that I reviewed in the last slide. Using the 7T MRI, we get very nice resolution detail of the central vein depicted on the left panel here, which is used for diagnosis of MS. You can see a classic MS lesion with a central vein coursing through it. In the upper right panel, on a specific sequence, we can see evidence of cortical lesions, which are unique to MS and evolve along the surface of the brain. And if you can see here, that red box is enlarged to show you two examples of intracortical lesions along the cortical ribbon. And the 7T MRI effectively doubles our ability to detect these lesions compared to conventional MRI. So we have new ways to find MS and new ways to follow it using higher resolution imaging. Below here, I'm going to talk about paramagnetic rim lesions, and in the bottom right, meningeal enhancement, which is a kind of enhancement which layers along the surface of the brain and we think is related to pathologies of progressive MS. So first to start, chronic active lesions and paramagnetic rim lesions. We've talked a little bit about this already, but chronic active lesions are chronic MS white matter lesions that are characterized pathologically by a rim of activated microglia. And that rim is associated with ongoing myelin degradation. And we know from histologic studies of MS that these are important in progressive MS. They are evident in close to 80% of SP-PPMS cases in one recent histopathologic validation study, and they have correlation with disease severity and disability. A subset of those chronic active lesions are further characterized as PRLs, or paramagnetic rim lesions. And these are visualized using special MRI sequences, T2 star and various susceptibility mapping. And what these sequences allow us to do is to see a rim that correlates with the area of iron accumulation from the activated microglia. And so the reason that we're reviewing this is that pooled studies in MS have shown that PRLs are found both in relapsing and progressive MS, 50% in relapsing and 60% in progressive MS cases. And in longitudinal studies, looking at patients who are worsening, progression independent of relapse, you can see that patients who are on therapies who have progression independent of relapse have higher baseline PRL counts. And later in the talk, I'll show how I think that PRLs at a baseline could be predictive of therapeutic response. And these are now adopted as supporting diagnostic criteria for MS, as was previously discussed. The other exciting area that I alluded to is cortical lesions. And again, these are examples from our 7-Tesla MRI scan. And what I showed you on the panel to the right is that the 7T MRI allows us to see histologic subtypes of MS that have previously been shown by microscopy. Type 1 are leukocortical lesions that develop along the gray-white matter interface, shown as the dark lesion next to the arrow. Type 2 are intracortical lesions that develop within the cortical ribbon. And type 3 are unique to MS subpeel lesions, which evolve along the surface and radiate inward. We think are the kinds of lesions that correlate along with disease progression. Studies have shown that these lesions, cortical lesions of any type, correlate with disability, with cognitive dysfunction, and both histologic and imaging work suggests they may develop independent of white matter lesions and offer a new imaging target to follow. Work from our group has shown that an interesting marker of meningeal inflammation called leptomeningeal enhancement may correlate with cortical lesions. And leptomeningeal enhancement is not the traditional enhancement of an MS lesion, but enhancement that develops along the surface of the brain that you can only see with specialized delayed contrast sequence. And if you wait to acquire the post-contrast image for 10 to 15 minutes, you will see areas of contrast enhancement that layer along the surface of the brain at 7T using the sequences we use. And we can find this at high rates using 7T MRI. Approximately 2/3 of relapsing MS subjects will have at least one leptomeningeal enhancement focus. And the reason we think that this is an exciting imaging marker is if you look at histologic studies of MS, there is diffuse meningeal inflammation along the surface of the brain, which correlates with the extent of cortical inflammation that you see in the microglia. And it would be very exciting and interesting to be able to follow MRI markers of meningeal involvement along with cortical lesions. And in the preliminary work that we've done, we've shown a relationship between the number and the volume of cortical and thalamic gray matter lesions and the presence of meningeal enhancement. Further work is needed to validate this in larger cohorts, assessing the impact of disease-modifying treatment. And lastly, I'll talk about the effect of brain and spine atrophy and its relationship to PIRA. So I've cited just two of many studies that are emerging looking at rates of brain atrophy and spine atrophy. And in the first study, which evaluated over 500 MS subjects, they evaluated relapsing MS that was stable versus those patients having progression independent of relapsing activity with a 3-year follow-up period. And what they saw was that there was clear evidence of increased brain atrophy, and that effect was driven by gray matter volume loss, and in particular in the cerebral cortex. So again, those cortical lesions that we know are evolving histologically likely contribute to brain atrophy, and ultimately the atrophy may be the appropriate marker, or one of the appropriate markers to track along with PIRA. In very nice work, similarly from the UCSF group, a study looking at patients who develop secondary progressive MS showed that faster rates of upper cervical spinal cord atrophy were actually able to predict those patients who were going to convert from relapsing to secondary progressive MS, and 4 years before the clinical designation of the secondary progressive MS transition. So these data would suggest that these imaging tools can offer a new biologic insight into the processes driving what we see clinically.
New work from many groups, including those on the NAMES Magnums consortium that Dr. Sicotte's a part of, have investigated the role of PET scans. This is new technology that allows us to look in real time, in vivo, for markers of inflammation. And the most used ligand, or the ligand that we're using in MS, is called TSPO PET. And it allows us to visualize active microglia, which are cells that you can't see by MRI, but actually are key mediators of disease progression, disease worsening, and do much of the downstream damage of many different neurologic diseases. And we can see that this is higher in patients with progressive MS, and it predicts disability progression, again, 4 years later. So I've kind of, in a brief amount of time, given you sort of the lay of the land of some of the key imaging markers that are related to risk of progression. And then I wanted to take a moment just to show you how these are helping us to inform treatments. And this is the part of the talk where I feel really optimistic. As Dr. Sicotte alluded to, there's a new class of drugs, Bruton's tyrosine kinase inhibitors, BTK inhibitors, that actually get into the brain. They impact B cell receptor signaling, among others, and have numerous downstream effects that affect these various pathways that I've outlined in progression. And many of our pharma companies are working to have these drugs come to market. When you first look in animal models, one of the really interesting observations is that in an animal model of progressive MS, you can see meningeal enhancement, you can see cortical lesions, and you can actually look under a microscope very easily at these lesions and their response to treatment. So in an animal study of this particular BTK inhibitor, after a treatment of 10 weeks, the animal showed reduced cortical demyelination, reduced meningeal inflammation, and an improvement in their disease score. This was major news when the first press release came out about tolebrutinib leading to an improvement in disease worsening, confirmed disability worsening at 6 months. And the key thing about this trial, the Hercules trial, is that it looked at tolebrutinib really for the first time in a very difficult to treat population. And I highlighted this in gray in the box, but non-relapsing means patients between EDSS of 3 and 6.5, that's up to a walker, no relapses in the previous 2 years, but with disability accumulation. So really targeting patients who are not doing well on their therapies and looking at a treatment goal that's actually has been historically difficult to reach, and that I think companies have been gun shy to try to target. We're very excited to see that the primary endpoint of this trial was met to suggest that there was improvement in the 6-month confirmed disability progression. And as it is in pharma, other companies will hopefully bring other drugs like this to market that will show improvements or further advancement of our understanding of how these drugs work. And as a final point to this, again alluded in the last talk, the patients who did the best, if you break down the effect of this drug on how, based on the imaging markers that I showed you, it is the patients who had PRLs, and actually those who had greater than 4 PRLs at baseline, having a 54% risk difference in that group. So it just shows you that the imaging markers of this progression are actually very relevant, not only to finding new therapies, but in monitoring MS and potentially response to treatment in the future. So I want to end on a very exciting new drug, which we are advancing at Brigham, and this is work done by Howard Weiner's lab and a number of others that was presented at AAN by Tarun Singhal, where we looked at an anti-CD3 nasal compound that was first studied in mice. And I put the picture up here just to remind us that this is all in animal, this data. But a nasal drug that targets CD3, we think goes through the cervical nodes, gets into the brain, calms brain microglia. And if you remember how we look at microglia from the imaging, it's through the PET scan. And so for our very first subject, we used FDA compassionate care, or it's called expanded access for those of you who don't know that. We took a patient who was worsening, and you can see the EDSS depicted in blue dots along the bottom of that graph, gradually over time in spite of treatment. Ultimately, the FDA gave us approval to test a PET scan before and after and treat the patient for a baseline of 3 and 6 months. And you can see Dr. Weiner and Dr. Chitness up in the upper corner doing the test nasal spray, which was just with saline, I'm assured. But here's the PET scan data. The purples and yellows on the left reflect that innate smoldering inflammation at baseline. And that's 3 months after treatment. So this was a very shocking and very potentially exciting discovery. The FDA gave us ability to do this for another 14 subjects, and that has now progressed to a phase 2 trial. This is one of the early patients to join in I should say later patients to join on expanded access, so I knew he was getting the drug. He was walking with a cane. He couldn't feel his left leg. He was really struggling to get down the hall. And I just make the point is that he encapsulates that non-active SPMS designation in terms of his level of disability, how he was really failing prior therapy. He went on the nasal spray drug, which is dosed Monday, Wednesday, Friday for 2 weeks, and then 1 week off. And then we monitored his walking, and this is how he was walking 3 months later. It's not perfect, but you can see he's getting down the hall with an AFO, no cane, and he's moving along. We treated him for another 6 months, and at that point when he came back, we actually had to increase our monitoring of his ability to walk around the hall to measure the distance. And at his best when he was on the drug, making it something like 400 or 450 meters without a cane or rest, which was a significant improvement. So this was a major platform presentation at AAN where we showed that the PET scan showed reduced microglial activation in these patients across the board in the first, I think, 10 or 12 patients who were treated. They showed clinical benefit in terms of fatigue, many of them in terms of their walking time or EDSS, and those 7T outcomes that I showed you are also stabilized. So I land there on that note. I'd like to again conclude that I think that my talk hopefully argues that there's a continuum of progressive pathology that we should be following from the early stages, that there are multiple mechanisms that can be monitored by neuroimaging. Hopefully, as we advance, they'll have more widespread clinical application, and that there's lots of reason to be optimistic about how they can be applied to the future of MS. So how I often frame the progressive discussion is that there's more research in progressive MS and more reason to be hopeful about the future than ever before. And I put a couple of slides here. This is the Boston Home for Progressive MS, and they do a free baseball game where kids and community members can come out, and actually on the right there's Rich Hill, Red Sox reliever, signing balls. Maybe they could have used him actually in the playoffs this year. But if you're ever in doubt about optimism in progressive MS, this is a great event, and it happens in August every year. So there's my talk. Thanks again for listening, and I'm looking forward to taking more questions in the Q&A session. Thank you.
I will introduce our third speaker this morning. Dr. Rebecca Gillani is an instructor in neurology at Harvard Medical School and a clinical scientist at Mass General Brigham. She has the distinction of being a recent the McCourt Foundation scholar. So some of the research funds that the McCourt Foundation has raised were applied to the research that Dr. Gillani has been undertaking, and we're really excited to be able to share some of her advances. I'm really excited to hear about her talk on redefining multiple sclerosis progression with a focus on cognitive dysfunction.
Okay, thanks everybody. So we're going to change gears just a little bit. Again, thank you to the McCourt Foundation for supporting the science work that we're going to talk about today. And it's important to recognize that multiple sclerosis is an important cause of disability. It's actually a leading cause of disability. Particularly, this is striking in young people who usually will not be developing disability early in their lives. And usually when we think about the disability that comes with multiple sclerosis, the first thing that comes to mind is the physical type of disability. So troubles with walking, falls, needing to use an assistive device to walk, or troubles with the hands, with discoordination or dropping of objects. But something that I hear in my clinic when I'm meeting with my multiple sclerosis patients is that the invisible types of disability can be just as disruptive to their lives. So this includes things like cognitive dysfunction, often described as brain fog. The types of cognitive symptoms that are most often experienced by people living with multiple sclerosis are troubles with attention, executive functioning, so like planning, as well as memory difficulties. And the other important invisible disability that people with multiple sclerosis live with is fatigue, which is also very common. And this cognitive dysfunction and fatigue can be very impactful on the person's life, sometimes even more so than that physical disability that they're struggling with. This is most obvious in terms of employment. So people at work may be struggling due to starting to make mistakes, having trouble keeping up with their projects, getting reviews back from their supervisors that they're no longer meeting the standards that they previously were able to. And unfortunately, many patients either have to change jobs, so go to a job that's less demanding, or even lose employment due to the fact that they're struggling with cognitive symptoms from multiple sclerosis. But this extends even more widely in the person's life as well. Of course, that employment loss or being underemployment leads to financial instability, and this can be truly life-changing in terms of thinking about things like housing and really fundamental changes in the person's ability to live their life the way they would like to. This can also lead to challenges in social functioning. So oftentimes my patients will describe that they're no longer able to do those extracurricular activities that they enjoyed in the past, and this can lead to a big change in the quality of life. And thank you for the kind introduction of the other two speakers who really set the stage really nicely for me to expand now talking about cognitive PIRA. So we already heard about this idea of progression independent of relapse activity in the context of physical disability. So again, just to recap, this is the idea that this gradual progression of disability can occur even in the absence of new relapses or disease activity, even from very early in the disease. And now we're recognizing just very recently that this idea extends to cognition as well. So there is this can be this gradual progression of these cognitive deficits that can occur in the absence of new relapses or changes on the MRI. And this is just one such paper who these authors describe this. So there's two things I want to point out. So on the left panel, you can see that of those patients who did have cognitive progression, most of that actually was not linked to new disease activity. That was independent from new disease activity. And then on the right-sided panel, this is something important because in clinical trials, we typically use an outcome measure called the EDSS, which primarily is measuring physical function. There's basically only one question about cognition in this scale. So it really does not capture very well this cognitive disability, which can be a very important outcome measure in treatments for multiple sclerosis. So what you can see here is that in those people who had the worsening of cognitive dysfunction but didn't have signs of new disease activity, most of that was not captured by the EDSS. So this really is not a good measure for this type of cognitive worsening. And one of the really important things to note is, like, when does this cognitive deficits start? Is this something that happens just very late in the disease after someone's been living with multiple sclerosis for a long time? Or is this something that starts very early? And the answer is that it does start very early. So people with clinically isolated syndrome, these are people who have had their first neurologic attack of multiple sclerosis but don't yet quite meet the diagnostic criteria. So they're patients at the very earliest stages of the disease. 35% of those patients even already have cognitive dysfunction at that very early phase. And I would even argue that there's some evidence that these cognitive symptoms might even start prior to the first diagnosis of MS, prior to people even knowing that they have multiple sclerosis. And you can see as the disease progresses, cognitive deficits become incredibly common with the vast majority of people struggling with these symptoms. And so what underlies this? Why is it this cognitive dysfunction starting so early in the disease? And this goes back, again, to something we've heard about already, this idea of neurodegeneration. So neurodegeneration, in the simplest terms, is just when the cells in the brain are damaged. In the setting of multiple sclerosis, this damage is related to neuroinflammation. So in this figure depicts that this neurodegeneration or damage to these brain cells actually starts very early in the disease and actually happens the fastest very early in the disease. So it's showing us that the atrophy or shrinkage of the gray matter is the part of the brain that contains the brain cells. That shrinkage is fastest early when people are younger in the disease. And also the shrinkage at the back of the eye is also fastest early in the disease. So these cognitive deficits and neurodegeneration are definitely not just a late finding in multiple sclerosis. They start from the very earliest time points, maybe even before the person even knows they have multiple sclerosis. And so we're going to change views. So we've looked at the MRIs, which is a sort of zoomed out big picture, and now we're going to look very zoomed in on the brain. And so one of the very important causes of this cognitive dysfunction and progression in people with multiple sclerosis is damage to those brain cells. So we're going to take a deep dive into that. So this is a really interesting figure. So these are dendritic segments. So a dendritic, basically a neuron has a cell body, and then it has a big tree of dendrites, so lots of extensions. And the dendrites are the parts of the neuron that receive incoming information. And then the neuron takes all that incoming information, computes it together, and then sends a signal out of its axon. And all of this incoming information to the neuron comes onto the dendrites, like I said, and it comes onto actually structures that are called dendritic spines. So these little protrusions off of the dendrite are where the excitatory synapses in the neuron are located. So all these little spiny structures actually represent a synapse or a connection between neurons. And what you can see is in a person who did not have multiple sclerosis, this is a very busy looking dendrite. There's lots of these little spines there, lots of information coming into the dendrite. But if you look in people, a person who had multiple sclerosis, there are much fewer of these dendritic spines. And so what this represents is a loss of synaptic inputs to this neuron. And this happened within demyelinating lesions, so in a location of inflammation, but it also occurred outside of the demyelinating lesion. So this is really something that can happen across the brain, not just within areas of discrete inflammation. Okay, so in our research, we wanted to ask the question, what's happening at that very earliest time point when the neuron is first being exposed to neuroinflammation? What happens to these synapses or these connections between the neurons? And just thank you to Sarah and Azaza, who did a lot of this work. So let me just walk you through what we're looking at. Very pretty pictures, but I'll describe what we're looking at. So in order to ask this question, we use an experimental model of multiple sclerosis in a rodent, and we use genetic and molecular techniques to label neurons and their synapses. So here, our neuron is labeled in red, and we've taken a picture of that in a living rodent. And then the little blue dots are all of the excitatory synapses residing on dendritic spines in that neuron. And then you can see there's a little yellow box, and then we're going to zoom in. And in the 3 panels at the top, what you can see is that these excitatory synapses actually change over time. So I think many years ago, we thought the brain was hardwired and that it had connections that were very stable and didn't change. We now know that's actually not true, and that synapses are constantly changing, and this is actually super important for learning and memory. These synapses have to be able to change in order to support new learning and memory. And so there's this normal, this normal flux of synapses where they're coming and going to support normal learning and memory. But when you expose a neuron to neuroinflammation in this experimental model, that process speeds up. So the synapses are less stable and they are coming and going more quickly. And so you can sort of imagine how that might affect cognition if you're not able to make those new connections that you need to be able to make to support your learning and memory and cognitive function. So the next question we asked is, are synapses in this setting of being unstable, are they still healthy looking? So to do that, we took tissue from these animals and we did an experimental technique that allows us to look at synapses in a very zoomed in way. So here we're looking at, again, a dendritic segment and those little protrusions off are those dendritic spines. And then on the tip of each of those is a synapse. And we're seeing actually the synaptic components. So a synapse is basically where two neurons come together to share information, and they have a presynaptic side and a postsynaptic side. I sort of think of it as a little hamburger. And these, what you can see is that in the neurons that were exposed to neuroinflammation, actually most of those synapses still had that pre and postsynaptic component. So they did appear to have their normal structure. There was only a modest loss of these synaptic components. So I think that's actually a positive thing, and that in early neuroinflammation, when a neuron is first being damaged, it still has that normal structure, so that if you can reestablish those, that normal flux of the synapses, we may be able to restore normal function to that neuron. And so now we've looked at structure of synapses. What about function? What happens to the neuronal activity, the activity of that brain cell? Thank you to Zurawski, who did most of this work. So to answer this question, we took the same experimental model of multiple sclerosis, and we expressed a protein called GCAMP in neurons. So here at this picture, we're seeing neurons expressing this protein, and this is a calcium sensor. So when a neuron becomes more active, it gets brighter. When the neuron becomes less active, it gets dimmer. And so what we see when we take pictures of this over time in mice is that there's a blinking as the neurons are active. So they get active, they become less active, so we can monitor the activity of the neurons. So what we saw is that in the setting of neuroinflammation, when these neurons are exposed to neuroinflammation, is that the neurons become less active. So the consequence of that inflammation on the neurons is that their activity is being suppressed. And what this led to, which is on the bottom panel, is that this led to less synchrony of the neurons. So synchrony is basically when the neurons are working together and firing together. As they were exposed to neuroinflammation, they become less active together. And finally, I've already mentioned excitatory synapses. These are the synapses that increase the activity of a neuron. There's another type of synapse called an inhibitory synapse, and this decreases the activity of the neuron. So we were wondering if there's decreased activity, is that because there are more numerous inhibitory synapses? And the answer is no. So there was no change in the number of inhibitory synapses. Again, that sort of speaks to the point that despite the function of these neurons being disrupted, the overall structure and overall structure of the synapses is still preserved. Okay, so what does this mean? I think bottom line is that I think what we think of about this cognitive era, I think that the pathologies we already heard about are very important, so that those chronic active lesions, inflammation in the leptomeninges at the edges of the brain. This idea that there is ongoing trapped, or what has been referred to as smoldering inflammation in the brain, that's exposing the brain to ongoing neuroinflammation, even if there aren't clear new spots of demyelination or clear new relapses in the patients. There's this ongoing inflammation. And what this does is we've already seen that neuroinflammation causes structural damage to neurons and synapses. In the long term, we saw that this leads to the massive loss of excitatory synapses. It also leads to the loss of neurons. So people living with multiple sclerosis have the loss of neurons in the brain. This leads to altered activity of neurons, even if the neuron has not yet been lost or the synapses have not yet been lost. And an important driver of this is also not just neuroinflammation hitting the neuron, but also demyelination. So if you demyelinate a neuron, it actually will lose synapses and become less healthy and change its activity. And finally, when you take this all together, this leads to changes in the way that the brain is working to process cognitive information. So all the different parts of the brain need to be able to coordinate together to serve cognitive function. And if they're not able to do that due to this damage and disconnection, then that leads to cognitive symptoms. So I think that there's some important conclusions that come from thinking about cognitive care. The first is that cognitive impairment starts from the earliest points in the disease and is an important cause of disability. That means that we need to be doing a better job in the clinic of identifying these cognitive symptoms early and treating them as soon as possible. I think that means that if we're thinking about neuroprotection and neurorestoration, we really need to think that that needs to start probably at diagnosis for the patient to have the best outcomes in the long term. Again, I already spoke to the importance of early detection. Cognitive rehabilitation can be very impactful for patients' functioning. So I think we need to be offering cognitive rehabilitation to patients who are experiencing cognitive symptoms very early in the disease course, not waiting till they're struggling at work and losing their job. And I think we really need, now that we're thinking about new treatment options, we really need to include robust measures of cognitive function as an outcome measure, and really look to whether we can also improve cognitive function in addition to physical functioning in people living with multiple sclerosis. And just thank you to the funders of this work, as well as people at the Massachusetts General Hospital who contributed to this work. Thank you.
Great. Thank you, Dr. Gillani, for that wonderful talk. I really enjoyed seeing the work that you've been doing and that the McCourt Foundation has helped make advances with your work. So now we are moving on to a question and answer session for the remainder of our time together. And Dr. Sicotte is again back joining us remotely. There will be, for those attending in person, a microphone that will be circulating. So if you have questions that you'd like to ask our panelists today, please raise your hand and alert those that will be circulating the microphone around. I also have some questions that were pre-submitted, so I will intersperse those with our live audience questions. I'm going to kick off a question to Dr. Sicotte. So all of us were in attendance at an international MS meeting just in the last 2 weeks in Barcelona, Spain, and there was cutting-edge research that was just presented, including updates on the diagnostic criteria that Dr. Sicotte presented, and including retrospectively applying the new criteria and demonstrating that these advances that we've incorporated into the diagnostic criteria really do have an impact on making our ability to make the diagnosis of MS earlier. My question for Nancy relates to, you talked some about the sensitivity and the specificity of our techniques, and being more sensitive to diagnosing MS is, I think, really important. On the flip side, the specificity end, can you talk more about that, specifically as it relates to misdiagnosis, and sort of how do we balance our sensitivity and specificity when we're making these criteria?
So thanks for that question. I think it's very important. And I think if we highlight these new imaging biomarkers, we can see how they play a role in making the right diagnosis early, but also avoiding misdiagnosis. And that's what we've been looking for. So for example, the central vein sign is very sensitive, and specific, but the paramagnetic rim lesion, I guess I see them as a 1-2 punch. So having the central vein sign allows you to look at white matter lesions, which are the most common reason why people get misdiagnosed. So white matter lesions are very common. They're caused by things other than MS, things like hypertension. Migraine in particular seems to be a common misdiagnosis. So the central vein sign can help us to identify those lesions as being demyelinating. And so they are very sensitive to that. There are some other situations where you can have a central vein. There's some subtleties to identifying the central vein. So it's very important that the criteria for calling something a central vein positive lesion are followed, and that's not always the case. So we do lose some specificity with the central vein sign. The paramagnetic rim lesions, though, are incredibly specific, as we showed and as the data have shown. And so that can be sort of the decider, if you will, for someone who you're not sure whether or not they're meeting criteria. Now, not all people who have MS will have a paramagnetic rim lesion. So only a subset of them. And that's a really interesting question also, because we think it's telling us something about prognosis. So it's not as sensitive as the central vein sign, but the paramagnetic rim lesion is very specific. So I see them both having a role, and I really am looking forward to the work that's being done to better understand how the paramagnetic rim lesions form, how they evolve over time, and what their meaning is clinically. And as we've heard about all of these changes that are going on within the brain that we're not necessarily capturing with our traditional imaging, that maybe this could be a target for therapeutic intervention that would make a difference. So I also think from the retrospective work that we've done with our CABS cohort, that about 25% of the patients who did not meet the 2017 criteria did meet it with the 2024 criteria. And that is a meaningful percentage of patients who could not be diagnosed previously, who now were able to be given a diagnosis and start therapy right away. I hope that addressed your question.
Yeah, thank you. Sorry, I'll move over here to this mic. Thank you for that answer. I see that there is someone standing with a microphone. I don't know if we have a question from the audience.
With all the research you're doing, when it comes to MS, is there one common biomarker that says that you can say without a shadow of a doubt it's MS?
Yeah, I think why don't we, as a panel, talk about this? So I thank you for that question. And we talked a lot about imaging in this particular session, but we also think about blood and spinal fluid in helping with diagnosis, and so I think those are other aspects that help. And as we talk about biomarkers, there's a few different types of biomarkers. We can think about diagnostic biomarkers, so biomarkers that help with making that accurate diagnosis. We also have biomarkers that can be predictive biomarkers, so a marker that perhaps we could check early in the disease, but could tell us something about how patients will do in the long term. And so those can also be really important measures to be able to determine in the clinic. And then there's also markers that we can use as we're monitoring patients over time, so that also becomes another category. So how are patients responding to treatments that they're on? But I'll just, why don't we go down the line? I'll start, we'll give Dr. Sicotte the last opportunity to speak, and we'll start with Dr. Zurawski.
Can you hear me here? They said the mic would be on.
I think that's on.
All right, well, if you guys can hear me. So it's a great question. Okay, so the phrase that you said is beyond a shadow of a doubt, and I think that that's still a challenge, right? Because in order to get at that, what that is implying is the specificity, and as Dr. Sicotte alluded to, these specific chronic active lesions with the paramagnetic rim, they have very high specificity, 99% specificity. But one of the frustrating things is even in relapsing MS, which most patients present to us with, only 50% have a PRL from the large pooled data set. There's some debate about what that number actually is, but just assume it's that. So you can have lots of patients who come to you that could have a PRL with very high, beyond a shadow of a doubt specificity, but you're not sure if they don't have it. And then you go back and you say, okay, well then it would make sense to have some kind of multiple score or multifactorial thing that you're looking at, where you have the central veins. And the story with the central veins is now, especially with the 7 Tesla imaging, you have very high resolution to be able to see the central vein within each of these little spots that show up in the brain. With that, there's a hypothesized 40% rule, and ideally you'd like to have something like 6 to 10 lesions on the brain. So you have to satisfy certain criteria on the MRI to really have the kind of specificity that your question asks. So I think it's really on the field to be able to put those imaging markers together to come up with a risk score surrounding it. I don't think there's a perfect marker yet. One thing that Dr. Clowder just alluded to was the ability of blood or spinal fluid markers to layer over this. I didn't have enough time to show you all of this, but you can take any one of those markers. There's really nice work that was presented at that conference in Barcelona on spinal cord atrophy, for example. And that was one of those markers that I showed you that precedes progressive MS transition by about 4 or 5 years. Now, if you take the blood biomarker, one of the blood biomarkers that we're very interested in, serum GFAP, it's a marker of inflammation and we think has a relationship to risk of progression. You take that and you layer it over the spinal cord atrophy, and now your ability to predict disease worsening is even better. So I think we need to do better to have the 2 different kinds of scientists come together. That's why symposia like this and other international conferences where we can see all the data together are really important, because the scientists talk to each other, we learn from each other, and we can think about ways that these different modalities can be put together to help patients. And I don't think it's unreasonable that, fast forward 5 years or so, that we actually have scores that in real time can take your MRI that you got that morning, can take blood biomarkers and really give you a sense of what the risk is of MS or the risk is of worsening with MS. That's a hard question to tackle right now because everything's very piecemeal, but I foresee that the field will move toward putting these markers together to really better understand, and hopefully right in front of you when you come into the clinic. And that's going to take a lot of coordination on the part of researchers to take these research findings and move them into the clinic. That's why these big imaging bodies and consortium between the scientists are important too, to put out there for the rest of the doctors how to use this information to guide patient care. So good question.
So I'll just speak a little bit more about the blood biomarkers. The idea would be, in the ideal world, that we could follow something simple like a blood test to understand the risk of progression or even the stage of progression that an individual patient is experiencing. So there's currently a biomarker that is now available to use in the clinic called the neurofilament light chain. But this one is best for identifying people who are going to have new activity on their MRI, so an enhancing lesion on their MRI. The way that the neurofilament light chain works is it's basically part of a neuron, and as that neuron gets damaged by inflammation, that breakdown product from the neuron leaks into the blood, and we can detect it there. We don't yet understand, more research needs to be done to understand how we can use blood-based biomarkers to do that other question, the question of progression. So looking at things like the GFAP, which was already mentioned. So GFAP being a protein that's found in a different type of cell in the brain called an astrocyte, which is a sort of a supportive cell in the brain. Astrocytes actually wrap around and protect all the synapses and support all the synapses. So if you can imagine, if we're damaging astrocytes, that's also a sign of progression. So I think that this is something that in the future, I think we are going to have blood-based biomarkers that will speak to progression, but we're unfortunately just not there yet. But there's a lot of people working on it.
Great. And Nancy, do you have anything to add?
Yeah, I will just chime in and say a quick answer to your question is no, we don't have a one biomarker at this point, and I want to emphasize, thank goodness, because that would put us out of business, right? But I would just say it's very important. The clinical context is very important, and for a lot of these neurological conditions, it does require a clinical presentation in order to make the diagnosis. Now we talked about RIS and how that can be an MS, but they're first and foremost, which I tell all the trainees, you have to rule out other causes. So there are a lot of things that can mimic MS, but we are moving slowly but surely toward these biomarkers, but it still will require a neurologist to interpret the presentation. Thank goodness.
Yeah. Job security. Okay. We've got another question from the audience.
First of all, thank you once again to the McCourt Foundation. I've been coming to these since they began, and it's been just such a valuable source of information. The question I have is for Dr. Rebecca, because you mentioned cognitive rehab, and I'm wondering, how do you rehab, a brain that's been destroyed? I don't understand what it would entail.
Yeah, that's an important question. So I think there's two main answers to that. One is that even if you're living with cognitive deficits, is that you can learn strategies to manage that. So let's give the example of someone struggling with attention. So if you're working in an office setting where you're in a cubicle and surrounded by other people, they're on their phone, they're doing meetings, this may not be a good environment for you to be able to have good attention. So in cognitive rehab, you can work with your cognitive therapist to say, how can I maximize my functioning given the deficits that I have? So that might be asking for accommodation at work, or using other strategies to maximize attention. Recognize, like, multitasking is not great when you have difficulty with attention. So learning strategies for preserving your cognitive energy and also directing it effectively. So this is how cognitive rehab, in one way, in a compensatory setting, can be very helpful in everyday functioning. So working in a very practical way with a cognitive therapist to figure out what are my challenges and how do I make this work better. The other is that one of the ways to help protect brain health is to stay cognitively active. So we see this both in multiple sclerosis, but also other neurodegenerative diseases. So probably by maintaining a active, healthy brain, by being mentally active, you may actually be able to do some of that rewiring, some of that restoration in the brain. So I think that it'll be great if we have a drug that can preserve cognitive function in the brain, but there are things that you can already do that are very simple things. Stay cognitively active, maintain a healthy diet, exercise. Exercise in itself may support repair within the brain. So there's things you can do now. Don't wait for that drug to be approved. Get out there, be active, keep your brain active any way you can.
Great, thank you. I'm going to take another question that was submitted, and I think that this is a question for any of our panelists. It relates to these common threads between neurologic disease, and I think the McCourt Foundation is a great example of trying to discover ways in which treating one neurologic disease perhaps translates to others. And so the question relates to, do you believe that discovering a cure for one neurologic disease could pave the way for cures for more effective treatments for others? So I know Dr. Zurawski talked about the idea of these activated microglial cells. I think that's one thread, and actually one of the treatments that he had talked about as being looked at in various neurologic diseases. So maybe I'll let you start with that, and then Dr. Sicotte, I know you as the chair of an entire neurology department are thinking about this issue.
Great. So can you hear me okay? Great. So to address the question, so how are diseases interrelated? So firstly, it's important to understand how MS is different, and then how it's the same as other kinds of diseases. And firstly, we know MS is sort of autoimmune demyelinating. That implies a very specific pathology that is different from Parkinson's or ALS. But as we showed, as I talked about in my talk, there's actually a very complex pathology, especially to progressive MS, which has a degenerative component. And one of the struggles in MS, as we know, is that we've not had good therapies to target that process in MS. Well, if that sounds familiar, of course, we all know someone who's been impacted by Alzheimer's, or you've heard stories of ALS or things like that. Also very difficult to treat conditions where the pathology is primarily driven by neurodegeneration. Eric alluded to this, but that medication that we talked about, nasal ferraliumab, it actually inhibits, or we think reduces, the microglial inflammation of the brain that we see in progressive MS. And we think that that's an important cell in progressive MS, mediating some of that end-stage damage. And if you look at in the same way that we did in my talk, looking at the pathology, the histopathology of the disease, and try to link that to imaging, you actually can see that the pathology of some other diseases, ALS, Alzheimer's, some variation of Parkinson's, have activated microglia as very relevant players in those stages of disease. So Dr. Weiner, who's the head of our center, some of you may know, he has a plaque outside of his office that says, "Cure as many neurologic diseases as possible," which it sounds like a mouthful, and like the goal is very noble, but the truth is that the second that this started to show some signal in MS, we started to forge collaborations with those studying Alzheimer's, multiple systems atrophy, ALS, and very rapidly that has snowballed into the same kinds of pilot trials, right? It takes 1 or 2 patients in a compassionate use program to volunteer because something is not working and they're getting worse. They volunteer, and maybe we see a signal that then is the match that lights the flame, and we get to move forward. So this is being actively studied in Alzheimer's. We're very hopeful. The very first subject with Alzheimer's that got the nasal spray drug, there's some sense of the signal being promising. Anytime you see one, I say, show me 100. And it takes time and money and energy to do that, and that's why we rely on collaborations with other specialists, with pharma, and with funders. It's a difficult time to get projects moving, but I think what I hope I showed you is that there is a path forward where if you're willing to explore these kinds of potential effects, sometimes you get lucky and you find them. And maybe for every 100, only 1 out of the 100 winds up being a success story. But you have to be willing to take that gamble. You have to be willing to be the first person to try it. And certainly we have patients in need with some of these other conditions that you talked about that are willing to try. And if we feel like something is safe to try, then we're willing to do it. So that's the story there. And then the last thing I'll say is that there's still a lot to learn about different kinds of neurologic illnesses through advanced imaging, through looking at the blood, through looking at spinal fluid. So we will move forward as a big field of neurology, paying attention to ways that PET imaging, that MRI can link to blood and spinal fluid to identify new targets. And so that's a very exciting area moving forward, where hopefully we will identify new targets and move forward new treatments that we couldn't imagine that could link different neurologic diseases together.
Okay, Nancy, I'm gonna move on to one last question because we're running out of time, but I'm gonna give you the
Okay, well, I'm going to interrupt just for
Yeah.
1 second to say I love that question. And the bottom line is it's all about the immune system. And absolutely, the information we're learning is being across all the different areas of neurodegeneration. And we're building a whole program on that. So anyway, sorry, go ahead. I know we're at time.
Yeah, so this is a question that was brought up to me from the audience, and so the question is, has the fight against MS been affected in any way by the federal government, such as research funding or introduction of new drugs? And I promise this question wasn't a plant, but but I'll try to answer this in one way. I think there are immediate effects and there are downstream effects. And as it relates to research funding, of course, the federal government, the NIH, has been an important source of funding, not just MS research, but research related to disease. And so as budgets dwindle, that means that less grants are funded. It also means that you have to really submit excellent science in order to get research funded. But I think it requires all of us as researchers to be extra determined. And it also means relying on more diverse sources of funding. And so that highlights the importance of the foundations like the McCourt Foundation or the National MS Society. I think it also means that we have to rely a little bit more on philanthropy in order to fund really important, novel, life-saving work. And also industry helps to sponsor research. But I'll take maybe a 5-second response from others in the panel. Yeah, go ahead, Nancy.
Well, I was just going to say there was a loss of a $50 million funding line in the DoD for multiple sclerosis. So that was the DoD MSRP continues, but not with the DoD funding continues, but not with a line specifically for MS. So that was a big loss. That's one tangible thing that's happened, I would say. And then everything else that Dr. Klauert has said, there's a chilling effect. And I worry about the next generation of researchers. It's very hard to do clinical translational research, and this puts up more barriers.
Yeah. So I'm going to go along the panel, and I like to end these sessions with on an optimistic or positive note. What is one thing that each of you is most excited about as we sort of look into the future for patient care, research, education?
You throwing it to me?
Yeah, go ahead.
I am an unabashed optimist. I think that there's a lot to be hopeful about with progressive MS, new therapies, new imaging, the ways that spinal fluid and blood will inform drug targets in progressive MS, which is good for everyone.
I'm very excited about the capacity for neurorestoration or neuroprotection. I think that'll come from new disease-modifying therapies that better target this trapped or smoldering inflammation within the brain. But there's also been some early results from remyelinating clinical trials that have shown some small improvements of measures on a visual test called a visual evoked potential. So far, we don't know that that makes any clinical difference in the long term in terms of the patient's functioning, but I think this makes the point that remyelination is possible. We just need to find the right drug to do that and treat for the right duration. But just to know, if you can remyelinate an axon on a neuron, that neuron can become healthier and restore some of its connections. So This can be one of the keys of restoring neuronal function is effectively remyelinating the axon. So I think there's a lot of excitement. I'm very excited about the future of neurorestoration.
And finally, I'll just give a little historical perspective and say that, you know, the patients who are diagnosed today with MS have a completely different outlook than 20 years ago. And I would highlight, for example, women who are of childbearing age who were told previously not to have pregnancies. And we now have lots of information to offer them and guiding them through this to successful pregnancies. And more and more patients who live with MS are living their lives to the fullest and doing what they want. MS is sort of an afterthought, and that is a huge move forward. So I don't think we should forget about that. And going forward, I am also very optimistic that we're going to be able to target both inflammation and neurodegeneration from the get-go with some of these new therapies, and really start thinking about combination therapy for patients and giving them, really putting them into remission for long term.
Thank you. I totally agree with all of our panelists. Thank you, everyone, for attending both in person and online. We really hope that this has been an informative morning for everyone. We also want to again thank the McCourt Foundation and all of our partners and sponsors for today's event. I know that there are more questions. There were submitted questions we didn't get to. I'm sure there's questions from the audience as well. I wish that we had more time to cover those, but for our panelists that are here in person, there'll be some opportunity to approach us as we conclude today's symposium. So thank you again to everyone, including each of our speakers, for presenting their very exciting work.